This is where you want to get your pillows out for your afternoon nap. And I apologize for giving so many lectures, but...
Excuse me, I'm providing the afternoon nap.
No. We're going to wake up for your talk. But they're really getting sick of hearing from me now. But this next, the first lectures were really about general management stuff. This is some really detailed information about a really specific problem that is just absolutely at the cornerstone of everyday rounds. As you guys know, every day in the neuro ICU, the question from the Lovenox puppet. Did you guys have a Lovenox puppet in your neuro ICU? It comes around and says, "When can we start the Lovenox? When can we start the Lovenox?"
I actually use a magic 8-ball.
Oh, I have an app. I've got the Magic 8-Ball app on the phone.
No. I found the magic 8-ball app, but it did not work adequately. So we went back to actual hard.
You're back to the real
Yeah,
deal?
real book, no Kindle.
I like the app because I can put my own answers in. Yeah, you can customize the answers like, you must be on track, or only with lots of prayer. So anyway, so we're going to talk about pharmacologic thromboprophylaxis in patients with hemorrhagic traumatic brain injury. So I'm going to present 2 studies that we conducted here at St. Anthony's. They're unfortunately retrospective studies, but they're large numbers and very interesting findings, and they've both been published in the Journal of Trauma now. So first of all, what's the problem? Well, we know that trauma patients are at risk for DVTs and PEs, and there is literature that demonstrates that early administration of pharmacologic thromboprophylaxis, or PTP for short, because I can't say that all day long, will decrease the risk of DVTs and PEs, or venous thromboembolism, VTE. You got to just remember these acronyms here, because I can't say them all day long. In trauma patients, general trauma patients. So the studies have been done in general trauma patients. And we also know that TBI is a risk factor for VTE. So there are several questions that are unanswered. One is, will PTP, or Lovenox specifically in our case, because that's what we use mostly, will it increase intracranial hemorrhage in patients following traumatic brain injury? And there are some recent studies, maybe not quite as recent as when we first started our trial, or our study, our retrospective review, that suggest that PTP is safe in patients with TBI. But the problem is a lot of patients were excluded from the studies, and the biggest exclusion criteria was the neurosurgeon didn't want the patient enrolled in the study because they were worried about hemorrhage. So there's an incredible amount of selection bias in most of the studies that have been published today until we get ours. And there's other problems, and that is about at least 25% of patients with traumatic intracranial hemorrhage will have some hemorrhage progression spontaneously without any intervention. And we're talking about anything from just a contusion blossoming a little bit to looking a little bit bigger to more significant hemorrhage progression. So the range, I have seen some studies as low as 8%, but most of them are 25% and higher if they look very carefully at any hemorrhage worsening on follow-up CTs. And currently, there's really insufficient evidence to determine the optimal timing for PTP or which patients should or should not have it. So this is what got us interested in looking at our own patients. So first, I'm going to talk very briefly about the risk of VTE in trauma patients and some of the studies that were done in the general trauma population and review those. Then look at the studies that were done regarding PTP in patients with brain injuries, and then review the problems with those studies, and then go over the data from our 2 trials. The first one had to do with ICH progression, the risk of ICH progression following Lovenox, and the other one was looking primarily at DVT and PE risk late or no Lovenox or interrupted Lovenox use, which turned out to be the most interesting group. So we'll do the hemorrhage progression study first, and then the interrupted Lovenox study second. So the risk of DVT, PE, and trauma patients has been studied for a long time, and the incidence really depends on how you're looking. Whether you're screening with venograms and finding 58% VTE rates, or Doppler studies, or only looking when patients are symptomatic. So the rates really depend primarily on how hard you look. The risk factors in univariate analysis include all of these things, including TBI, of course, at about a 2.5 odds ratio, but ventilator days over 3, venous injury, major surgery, even higher risk. And in a multivariate analysis, you can see TBI actually is not a huge risk factor in a multivariate regression, and that ventilator day stands out as the biggest risk factor for VTEs in trauma patients. So just a quick review of the literature. Knudsen et al. in 96, almost 500 patients that used low molecular weight heparin and had a VTE rate of 0.87. Pneumatic compression devices, 2.5%. AV foot pumps, about 5.5%. Gertz in the New England Journal in 96. Low-dose heparin was 44%, and low molecular weight heparin 31%, but they were screening with serial venograms. So they're finding a lot of DVTs when you do that. Nathan's et al. Was a study done here at Denver General. Gene Moore is one of the authors as well. In 2007, 311 trauma patients with clinical VTEs. And in patients that had PTP started within 48 hours, they had a VTE rate of 15%. And if it was started after 4 days, the rate was 3 times higher. And this was clinically significant. And they noted that TBI was one of the most common reasons that PTP was delayed. And so this study got a lot of attention. Everybody said, oh, those brain surgeons are bad. They're making us hold Lovenox and heparin. They're not letting us treat prophylactic for VTEs. And look at this, the rate is 3 times higher if we don't start it early. So then people started looking more specifically at Lovenox and heparin use in TBI patients. So Kim et al. In 2002 published this very small retrospective review of only 64 patients. They used heparin BID. They defined early as less than 72 hours and had about 47 patients in that group, late after 72 hours. And the initiation was determined jointly between the trauma surgeons and the neurosurgeons. So again, you have selection bias in terms of who gets started when based on what their scans look like and how worried we are. And what they found, or what they reported, was that they had no increase in intracranial bleeding or deterioration that they attributed to the heparin group. And they didn't really get into specifics. This was just kind of a statement that they made. They also found no difference in VTE rates between the groups, but it's a small, very small sample. And from this, they concluded that early heparin doesn't increase the risk of bleeding complications in TBI. So we're well on our way to proving that it's safe, right? Well, I don't know. Is it safe? Norwood published this in 2002. 150 patients. This was a prospective observational study. They used Lovenox, 30 milligrams BID. And it always amuses me that the trauma surgeons have this absolute ironclad contraindication to using PTP in patients with splenic injuries for 72 hours. But if there's blood in the head, that's not a problem, right? So if the spleen leaks a little bit more, that could be dangerous. But if you bleed a little more in your head, who cares, right? So this is, we're all among friends, right? I've given this talk at the American Association of Trauma Surgeons too. They loved it. Presented the first study there. They didn't know I was a neurosurgeon. At the end, they said, "How did you get the neurosurgeons to agree to let you do Lovenox?" And I said, "Well, I hate to tell you, but I am a neurosurgeon." Everybody broke up laughing. So anyway, they had 28 patients had ICH progression even before they started, before they enrolled them, basically, before they got Lovenox. So that's kind of their baseline hemorrhage progression rate, about 20%, just on their first follow-up CT scan before they got it. And they got they got Lovenox anyway, and they reported no new intracranial hemorrhages in the patients who got Lovenox even after their first follow-up scan was unstable or demonstrated hemorrhage progression. And you'll see why that's important later. They reported that 6 of their patients, or 4%, had ICH progression after PTP, and one of those was the progression of an epidural hematoma that was enough to require craniotomy. And 2 patients out of 24 that had a craniotomy, or 8% after cranium, required reoperation. And 27 of the patients were excluded from the study, primarily again from neurosurgeon reluctance. So a biased population, and they did have some complications. 1 hemorrhage progression big enough to require a cranium, and 2 return trips to the OR for hemorrhages after craniotomies. And yet their conclusion is that Lovenox is safe to start 24 hours after hemorrhagic TBI.
Stuart?
Yeah.
Craniotomy means exactly what? Small burble?
No, craniotomy means
Craniectomy?
no, it means turning a flap. So a burr hole is just drilling a hole, and that's really only effective for draining a chronic subdural hematoma. With a few rare other exceptions, that's about all we use it for. So craniotomy means actually turning the flap, taking out a bone, taking out a piece of bone, evacuating hematoma, and whether you put the bone flap back in or not is how you determine whether that's a craniotomy, open and close, or a craniectomy, leave the bone flap out.
I'm actually just kind of surprised that it's that low, because my experience is coiling aneurysms after attempted clipping, because you use heparin during aneurysm coiling, they all develop subdural or epidural hematomas underneath the bone flap. So 8%, I'm surprised.
Yeah, well, if we're talking about prophylactic doses and not therapeutic doses, though. Yeah.
Why do you use Lovenox rather than heparin?
Well, that's a good question.
It's a huge cost difference.
I don't know if the cost difference is that much anymore. Does anybody know?
Oh, it's much more effective.
Yeah, I think it's more.
There is a decreased risk of DVTs with Lovenox compared to fraction.
Yeah, especially in surgical patients.
In trauma patients, right, but in surgical patients, which is who we're talking about.
So I don't think the cost difference is as much as it was, and the efficacy is better. I don't know if the complication rates are lower.
Complication rates were higher. And there's a large unstudied population, two large unstudied populations.
One of which we're talking about now.
And the other one was spinal cord injury.
Yeah, and that's a contraindication. I mean, in all of the studies, they exclude the spinal cord injuries from the studies. Now, whether they use it or not at some point along the way is a whole other story. But
And 2/3 of them get DVTs, if you look at the studies of spinal cord injuries.
yeah, especially
Whether they're
if
clinically relevant or not.
right, if you're straining,
Yeah.
the rate's extremely high. All right, so here's another study, 124 patients retrospective. Only 54% of them though had follow-up head CTs. In this study, they used Lovenox and heparin back and forth. They didn't separate the groups, so that's a little bit messy. They had an early, a late, and a no group, and contraindications included these kind of vague things like significant intracerebral or intracranial hemorrhage with potential ongoing mass effect, progression of ICH, which I think turns out to be probably the strongest indicator for withholding PTP, pre-existing coagulopathy, or imminent ongoing hemorrhage from a solid organ. There's the splenic injuries again. And in this group, 3 patients did have progression of their ICH after PTP, and 1 in the early group required craniotomy, and the other 2 were in the later group. The other thing that's interesting, again, the study's sample is kind of small. but there was really no significant difference in the DVT or PE rate in their group. And so whether they got treated early, late, or never, there was no significant difference in the DVT and PE rate. If anything, you know, the group that got none had the lowest rate, but they were probably the lowest risk group. What we found in our study is that a lot of patients who never got Lovenox probably didn't need it either. They're patients that are getting up, they're ambulating early, and going home in a shorter period of time. And they concluded that early PTP seemed safe after TBI with a stable intracerebral hemorrhage. So they did exclude the so-called unstable ICHs, or patients who had a change on their follow-up CT scan. And then Norwood published this. This is the one that's probably the most commonly quoted by the trauma surgeons, published in 2008. And there were 525 patients reported in the study, but it was gleaned from a population of over 2,000 patients with TBI, multi-trauma patients with hemorrhagic traumatic brain injuries, over 2,000. So 75% of the patients, 3/4 of them were excluded from this report. And they got Lovenox within 48 hours. And these are some of the reasons for exclusion. You know, bigger hematomas, multiple contusions, and of course liver and spleen injuries, and neurosurgeon reluctance again. So, and they don't give any report about hemorrhage progression or complication rates in the excluded patients, but they did report DVT and PE rates now. So, first of all, their VTE rate was very low, just a little over 1% in the 525 patients in the study group, and it was only 0.83% in the excluded patients that they reported. There were 1,500 excluded, but that's who they reported on. And ICH progression was seen in 8% before the Lovenox was started, and then in another 3.5% after Lovenox. And 6 of them were clinically significant, 3 required craniotomy, and 1 death from hemorrhage progression after Lovenox. And their conclusion now is a little bit softer than their first one. It says that Lovenox should be considered as an option in selected patients with blunt TBI. So they did soften the recommendation a little bit. And the problems with these studies are many. First of all, a lot of patients were excluded for a lot of different reasons, and sometimes it wasn't even clear why they were excluded. Mostly because the neurosurgeons were reluctant to let them have Lovenox, so there's selection bias that the highest risk patients are already being taken out of the studies. A lot of the studies are too small. The biggest study didn't analyze the ICH rates in the excluded groups. And this is really the elephant in the room, is that no one today has shown any clear benefit of Lovenox or heparin for the prevention or decreased rate of DVT and PE in patients with TBIs. None of the studies show any benefit. You look like you want to say something. Please feel free.
How can it possibly, when all the patients at the highest risk are excluded from observational studies, from the intervention in a quote observational study, and you have selection bias and confounding by indication. Surprise, surprise. The complication you're looking for, the people who already have it are excluded.
Right.
So, surprise, surprise, surprise.
Have you seen any studies that demonstrate any benefit to Lovenox or heparin in the TBI population?
So not back pain, but just as disclosure, I was the lead reviewer for the 2011 latest issue of the guidelines for the management of severe brain injury. This was my subject. And the biggest problem is you can't get data where neurosurgeons have not allowed patients to be.
Right.
And that's been the biggest problem. In fact, we led a 20-center group to the, now Upjohn, they rest in peace, originally, and then we bought it from the daughter parent. And the problem is that we can only get 7 of the 20 centers where the neurosurgeons, at least 2 of the neurosurgeons there, were would agree to allow, quote, high-risk patients that they weren't comfortable with to receive drug. So ultimately, we had to just say, write the study off as undoable, because the biggest problem was people with equipoise like yourself are few and far between. And the statement is pretty straight. It says, we can't tell you anything about what to do in the first 48 hours. And the reason is, it's not that it's not safe, it's that there are no real data. I can tell when you get done, I'll tell you how I interpret all of that.
Okay, good. Yeah, I definitely want
Which
to hear
is,
what you have to
which
say.
is, of course, the only right answer.
Yeah. It's like 4 evidence,
Oh, a
right?
nice font, too.
Yeah, type 4. Oh, the font is all that really matters on this talk. And apologies again to anybody who's colorblind. You can't see on the red probably looks really great. Anyway, so that's one of the biggest problems, is that there's no clear evidence, but the studies just aren't there to tell whether it's beneficial or not. We just don't know. And we all know, anecdotally, we've all seen clinically significant hemorrhages after Lovenox or heparin in patients with intracranial hemorrhages of all types. And how many ICH progressions and deaths is really acceptable? In the last Norwood study, they had a death from ICH progression, but no deaths from BDs. So, and that was a big study. So, what are we doing? Are we really helping anybody? And the biggest problem of all, and this is not so much the problem here anymore, because we've really addressed this topic, and trauma surgeons are co-authors on these studies that we published. But before we did this, especially here, probably all over the country, the trauma surgeons have often glanced at these studies and interpreted the conclusions to simply mean, or to believe that Lovenox is safe to give in all patients with TBI, because that's what some of the conclusions look like. So we undertook a retrospective review to look at several things. And the first thing we wanted to look at was whether or not PTP increases the risk of hemorrhage progression in patients with TBI, and if so, which ones. And then we wanted to look at the overall incidence of hemorrhage progression on that first follow-up CT scan before we give Lovenox. And then afterwards, we also tried to define which percentage of these would be clinically significant. This is hard to do in a retrospective study, and so it's one of the major flaws. And we also, of course, we looked at DVT and PE rates between the groups, but the second study looks at that in more detail. So the first one's mostly about ICH progression. It was a retrospective study. We had 340 patients, adult patients, and their length of stay had to be at least 3 days. Because anybody with a mild injury that's going home in less than 3 days really doesn't belong in the study. It's not really a major issue for them. And blunt TBI diagnoses, and we had an admission order set. The trauma admission orders, as many of you know, had a standing order in them for Lovenox, 30 milligrams BID, started 36 hours, unless held by the attending neurosurgeon. There's that neurosurgeon reluctance factor in there. So we are, prey to the same exact problems that all the other studies had, in that we selectively excluded patients from getting Lovenox if we thought they were at high risk. But the difference is we analyzed them in a way that nobody else did, and I'll show you that in a sec. All of the patients had follow-up CT scans within 24 hours of admission. And we defined progression of hemorrhage on follow-up CT based on the radiologist reading of the follow-up CT. If there was any increase in the hemorrhage they presented with, or any new hemorrhage. So new hemorrhage or increased hemorrhage is defined as hemorrhage progression. And then we tried to define potentially clinically significant hemorrhage progression as a hemorrhage that either changed the patient's management or their clinical condition. So if they required a neurosurgical procedure like a craniotomy, a ventriculostomy, or if the study was ordered because of a decline in their neurologic condition, or they were transferred back to the ICU because of a decline in their condition, or if an ICP went up more than 10 points, or went from below 15 to greater than 20, or if they had a 2-point drop in their GCS. So this is one of the biggest flaws of trying to define clinically significant hemorrhage progression retrospectively, is it's kind of messy. And then we look for associations between ICH progression and the timing of the Lovenox, early, late, or never, and whether they got Lovenox before or after their ICH progression. We use logistic regression, and we divided the study into 2 groups. And group 1 are patients that had a stable initial follow-up CT. So their morning after scan showed no change. That's group 1. Those are stable patients. Group 2 were patients who had some kind of ICH progression on their follow-up CT, their first follow-up CT scan before they ever got Lovenox. So they're unstable or they have hemorrhage progression before they got Lovenox. And then we analyzed for subsequent hemorrhage progression on later follow-up CTs in that group. So of the 340 patients, 2/3 were male. ISS score was over 20. Max head AIS 4. GCS mean was 11.5. And about 30% of the patients had multiple injuries, and you can see the breakdown of their intracranial injuries here, a typical mix of traumatic brain injuries. 65% of the patients got Lovenox, and about half of them got it within 72 hours, and about half of them got it after 72 hours. 35% never got Lovenox, and 20 of the patients probably didn't need it. It's hard to define, it's hard to be certain, but they had milder injuries and they were up and ambulating early. And 98.9% had pneumatic compression devices, and I have no idea why that's not 100%. It should always be 100%, right guys? I've never seen a study where it's 100%.
Unless you're sitting in a whizzer
Yeah, I guess if both legs are in traction, yeah. So the overall ICH progression rate was about 32%. And this was on any follow-up CT, including the ones before they got Lovenox. And 27% were on the initial follow-up CT, 92 hemorrhage progressions before they got any Lovenox. And clinically significant hemorrhage progression rate was around 20%. Again, it's a retrospective definition, so it's a fault of the study, but this is our best attempt to define potentially clinically significant. Our combined DVT and PE rate was a little over 5%. When we looked at the variables associated with hemorrhage progression, we found that age greater than 55 was significantly associated with increased risk for ICH progression. Interestingly, pre-existing use of Coumadin, aspirin, or Plavix was not associated with an increased risk of ICH progression in this study. There is a trend, but it didn't reach significance. A severe TBI with GCS of 3 to 8 left patients with a higher risk of hemorrhage progression compared to the other 2 groups. Subdurals had a higher rate of progression, and other unspecified ICHs and contusions, which, as you know, there's kind of a blur between these 2 kinds of injuries depending on how big it is. And the isolated traumatic subarachnoid hemorrhages, which are those little tiny spritzes of blood in the convexity sulci, had a significant difference, but it was in the other direction. These patients were at significantly lower risk for hemorrhage progression, as you would expect. So these patients are probably, almost always going to be safe to be on Lovenox, and they tend to have good outcomes, as you know. And then this last line is really important, because if you looked at mortality rate in the group with ICH progression compared to those who had no progression, there was a very significant difference. Almost an 8-fold increased risk of dying if the patient had hemorrhage progression for any reason. That's not implying that all of these were from Lovenox. But the point is that these hemorrhage progressions, as we define them, are not clinically insignificant. That this group had a significantly higher mortality rate. So this is the easiest way to kind of look at the results in this graphic form. The first question is, did they have any hemorrhage progression on their first follow-up CT scan, the morning after scan? In group 1, for the 200